everyone, and welcome to a new session of clinical pharmacology and clinical research. And today videos we are going to discuss the Bloom's taxonomy for asthma clinical pharmacology questions. And the purpose of this lecture today to address the level of questions and the level of difficulty of the question, or the level of evaluation of the question. So we have the basic level, start from remembering, moving to the higher level, understanding. The third level will be applying. Next we have analyzing. Then we have the higher one will be evaluating. Then the highest one will be creating. So we are going to apply Bloom's taxonomy to the asthma clinical pharmacology question. Regarding the first one, the first level will be remembering, and here we test the knowledge and recall. And here we will bring like basic recall of facts, definition, and drug properties. The example here, which of the following drug is short-acting beta adrenergic agonist used for acute asthma relief? We have A. Salmeterol, B. tiotropium, C. albuterol, or D. montelukast. So the correct answer will be albuterol, Ventolin, or Broair, or Proventil. Okay, the first one here on the list, salmeterol. Salmeterol long-acting, not short-acting. Tiotropium belong to the muscarinic antagonist. Montelukast belong to the anti-leukotriene. So the short-acting beta-2 agonist will be albuterol. Okay, moving to the next level of Bloom's taxonomy. And this level regarding remembering knowledge, as you can see here. The second level, understanding, comprehension. And here we need to interpret, summarize, and explain the information. Why? Why is montelukast considered more suitable for long-term asthma control rather than acute attack? Why we don't use it for acute attack, we use it for long-term asthma? A, it causes rapid bronchodilation. B, it inhibits histamine release. C, it blocks leukotriene receptor. Or D, it stimulates beta-2 adrenergic receptor. So the correct answer will be black leukotriene receptor. So here we talk about leukotriene, as you can see here. Okay, talk about montelukast, and montelukast inhibit leukotriene receptor. Okay, it's not belong to the beta-2. It's not belong to the histamine. It's belong to the leukotriene receptor. Okay, level number 2. We move to the level number 3. Okay, applying information, application, using knowledge in a clinical scenario. Here we have patient with asthma experienced tremors and a palpitation shortly after using an inhaler. Which of the following most likely responsible here? Beclomethasone, ipratropium, cromolyn sodium, albuterol. Proventil, Broair, Ventolin, albuterol. So which of the following responsible for tremors and palpitation in this patient? So here we try to use the knowledge in a clinical scenario. So we use the medication, we apply the medication, and the medication causes side effect. Which of the following medication may cause a side effect? Here we apply the information. So what do you think the correct answer here for applying the information? So the correct answer will be albuterol. And the explanation for that, because albuterol stimulate beta-2 receptor, And also albuterol has some stimulation for the central nervous system and some stimulation for the heart. For this reason, the patient may suffer from tremors and palpitation. Okay, the third level will be application. Moving to the level number 4, analyzing or analysis. Here we need to break down the complex clinical cases, compare drug, evaluate lab data. The question here, which the following explain why thiophelline use is declining in asthma management? Okay, why thiophelline declining in asthma management? Number 1, poor oral presentation. A. B. Narrow therapeutic index and drug interaction. C. Rapid onset of action. Or D. Inability to reduce airway inflammation. Okay, so the correct answer will be narrow therapeutic index and drug interaction. Okay, poor oral bioavailability is just not correct because we have oral, it's available oral, we have thiophelline available oral. Rapid onset of action, no, it's not correct because this one could be like oral take like 30 minutes to 1 hour to start working. Inability to reduce airway inflammation, no, able to reduce inflammation. So thiophelline reduce inflammation, and thiophelline cause bronchodilation. Two things. Okay, however, the thiophelline is considered like narrow therapeutic index, and we call this one narrow therapeutic index (NTI), and also the thiophelline present cardiac maybe drug interaction and stimulates central nervous system and may cause a seizure. And this one, as you can see from the question, analyzing, we try to analyze. Okay, which of the following explain why thiophelline is declining? We try to explain, evaluate the situation here. Okay, moving to the evaluating or evaluation, making judgment based on criteria and prioritizing treatment. The question here, which of the following is the most appropriate step-up therapy for a patient with asthma uncontrolled on low-dose corticosteroids? Okay, here the patients are from asthma and uncontrolled asthma with a low corticosteroids. Which of the following the most appropriate to step up therapy here? Add therapy. Number 1, add corticosteroid daily, add oral corticosteroid daily, add long-acting beta-2 agonist, replace corticosteroid with a leukotriene inhibitor, or add anticholinergic inhibitor. Okay, the correct answer will be add long-acting beta-2 agonist LABA. Okay, so for asthma, we start with the inhaled corticosteroid. If the patient does not respond, I go to escalate the therapy, step up therapy, we can add LABA. So maybe the next step here, adding LABA to enhance efficacy of the treatment. This is evaluation here. We evaluate the situation. The patient need to control uncontrolled symptoms here. We evaluate the situation. What is the next step here? We add long-acting beta agonist. Okay, moving to the last step, creating or synthesis, formulating treatment plan. Here we talk about a plan, modifying regimen of treatment based on the patient context. So here we have 30-year-old patient with a frequent nighttime asthma symptoms, is currently on albuterol. So the patient suffers from frequent nighttime asthma symptoms, and he's currently on albuterol as needed, PRN as needed. What would be the best next step in building maintenance therapy plan for this patient? And we can look on the plan here. So you can see the plan here for number 6, creating synthesis, formulating treatment plan, modify. So the patient on already on albuterol, but he suffer from frequent nighttime asthma symptoms. So what would be the most next step building maintenance therapy plan for this patient? Number one, continue BRN albuterol only. B, start low dose inhaled corticosteroid. C, start leukotriene receptor antagonist only. Or D, prescribe thiophelin daily. Okay, the correct answer will be start low dose inhaled corticosteroids. Okay, so inhaled corticosteroid. So when you have patient on albuterol, especially when you have intermittent asthma, and the patient start maybe suffer from more severe asthma, like the situation need more control, we can add inhaled cortisone. Okay. Okay, this will conclude our maybe brief Bloom's taxonomy regarding clinical pharmacology asthma question. We address 6 level of the therapy. Next, we are going to have Bloom's taxonomy application for peptic ulcer disease clinical pharmacology question. Thank you so much.